much. The challenge. It's a pleasure, and it's my last presentation of the director of the endTB project, which was a long-standing collaboration between MSF and other major NGOs such as PIH, IRD, and all the other partners that you can see here. But it's definitely not the last time you will hear about the endTB project, because there is so much more left to do. First of all, let me start by thanking all the trial participants, more than 300 participants. We had more than 1,000 patients across many countries that accepted to be screened for the study, and the hundreds of people who worked in the operational team, and a few of the more faithful are here today. I want to thank Mathilde, Mylène, Marava, Audrey, and Laura. And now a few words about the trial design. First of all, so this endTB-Q is a randomized, controlled phase 3 trial looking at patients with pulmonary tuberculosis with pre-XDR-TB, which is pre-extensively drug-resistant TB. We define as the resistance to both the most effective first and second line drugs, namely rifampicin and fluoroquinolones. And we included adults and adolescents of 15 years of age or more. In this trial, we compared a stratified duration strategy of 6 to 9 months. We will see more about that later, using a regimen including 4 drugs: bedaquiline, delamide, linezolid, and clofazimine. We will refer to that as BDLC in the presentation, to a standard of care control, which was the individualized long regimen of 18 months of duration. And the design, as Mark mentioned, was non-inferiority, meaning that we wanted to show that the intervention is as a similar, or at least not worse, efficacy than the comparator, because the advantage would rely mostly in the reduction of 50 to 60%, 63% on the treatment duration, and expected reduction also of the adverse events. So the stratified duration strategy was assessed looking at baseline characteristics of study participants. We looked at the chest X-ray, if there was a presence of any lung cavity, and also at the highest smear grade in the semi-quantitative evaluation of the sputum taken at baseline. And combining these two variables, we will define the extent of disease as extensive or limited. And after that, patients with extensive disease would receive 9 months of treatment, while patients with limited disease would receive 6 months, unless they had a delayed treatment response, which we assessed by looking at sputum culture while on treatment. In that case, we would prolong also patients with limited disease to 9 months. So now coming to the results of the endTB-Q trial, we first of all achieved to enroll the targeted sample size of 323 participants across 10 sites in 6 countries. And as you can see, 80% of participants were included in countries with very high prevalence of pre-XDR-TB, such as India and Pakistan. Out of the 323 randomized participants, we included in the safety population 318 who actually started treatment, and then 247 in one of the co-primary analysis population, the modified intention to treat on MITT, which included participants who had a positive culture at baseline, confirmed fluoroquinolone resistance, and no resistance to the drugs in the experimental regimen. And 233 participants included in the per protocol, or PP, the other co-primary efficacy analysis population, where we included MITT participants who also followed a protocol adherent course of treatment. Now, having a look at the baseline characteristics in the MITT population, I would like to draw your attention on, first of all, the 7.3% of participants who were minor, so adolescents of 15 to 18 years of age. We had a low overall prevalence of co-infections with HIV and other viral hepatitis, as you can see, high rates of diabetes, and overall 2/3 of participants had extensive disease based on the presence of cavitation and the positivity of the sputum smear at baseline. So now looking at the control arm in particular, this is important to draw your attention on, but first of all, on the duration, which was 18 months for most participants, as expected. In terms of the composition of the control arm, this was very similar to the experimental arm, with over 90% of study participants who actually received the same regimen, BDLC, plus one or more drugs. So a very similar but fortified regimen and given for a longer period. Now coming to the primary endpoint on the efficacy results, which is the proportion of favorable outcomes at 73 weeks post-randomization in the MITT population. You can see here the results, and overall we had excellent results in both arms, with more than 86% of treatment success in both the experimental and the control. We were very happy to see that the results in the control were really amazing. However, they actually outperformed the experimental arm, which was not expected, of course. And so looking at the unfavorable outcomes to try to understand the reason for this difference, you can see here there is actually no difference in mortality rates, in poor treatment response, and also in permanent discontinuation due to adverse events. So the main difference comes from these two outcomes here. So first of all, recurrence rates. We had 5% of recurrence in the experimental arm, while there were no recurrences in the control, and we had more loss to follow-up and consent withdrawn in the control than in the experimental arm. This was expected, and actually these rates are lower than what we were imagining. So this all leads to our primary comparison between the experimental arm BDLC minus the control compared in the forest plots. Here you have above the MITT and below the per protocol, the two co-primary analysis populations. You have the point estimate of the difference in the adjusted analysis here and the 95% confidence intervals for both comparisons. And this is the pre-specified non-inferiority margin of -12, and as you can see, in the MITT, non-inferiority was the lower bound of the non-inferiority interval does not cross the -12, while this is crossed in the per protocol population. So in conclusion, we cannot conclude for non-inferiority of the experimental strategy to the control. And to try to understand a little bit better why we came to this conclusion, we performed a pre-specified analysis stratifying by extent of disease at baseline, were defined as we have seen before. And here you can see that although there is no statistically significant difference, there is a trend towards better outcomes in the experimental than in the control, in the limited disease group, while in the extensive group we have a trend in the opposite direction. And the last element of our analysis of the efficacy results is looking at recurrences. So this is a Kaplan-Meier curve showing time to recurrence after the end of treatment in each arm, which is stratified by arm and by baseline disease extent. You can see, first of all, in green, here below, you have the control arm where there were no recurrences. It's important to note that the follow-up time in the control arm was around 6 months, so much smaller than in the experimental regimen, where the follow-up was much longer, over almost 1.5 years. And you can see the difference between patients in the experimental arm who had limited disease at baseline, where we had only 1 recurrence, and those with extensive disease, where we had 8 recurrences. So all these 9 recurrences were actually confirmed to be relapsed by whole genome sequencing, meaning that the strain who recurred was actually the same strain that was present at the beginning, isolated at the beginning from the same patient. And in 7 out of 9 of these confirmed relapses, we found acquired drug resistance, mostly to bedaquiline and clofazimine. Now, a few words about safety, really quick. So if you look at the primary safety endpoints, we had the overall rate of any grade 3 or higher adverse event, any serious adverse event, and any drug which was permanently stopped due to adverse events. And in all these comparisons, you can see that we have a higher proportion of adverse events, events in the control rather than in the experimental regimen, which is expected because of the different duration, of course. And if you look at the adverse events of special interest, which were the ones related specifically or expected to be related specifically to the drugs used in the experimental regimen, we had high rates of these two first adverse events, which are usually related to linezolid use, myelosuppression, and peripheral neuropathy, and they were both more frequent in the control than in the experimental arm, which once again was expected because linezolid use was prolonged in the control arm, and also in the experimental regimen we had a structured dose reduction after 4 months. While the 3 other adverse events of special interest, hepatotoxicity, optic neuritis, and QT prolongation were actually not very relevant in our study. Which leads us to the final conclusions of the trial. So first of all, we found that the experimental regimen of 6 to 9 months of BDLC for pre-XTRTB patients had a high cure rate of 87%, so very good results. However, these rates were actually slightly lower than the long control regimen, and therefore non-inferiority was not established. In patients with limited disease as baseline, as we have defined them, the 6-9 BDLC regimen showed excellent results, and actually we think that this regimen could be preferable to the control in this population due to much shorter duration, lower pill burden, and better tolerability. In people with extensive TD disease at baseline, however, even 9 months of BDLC were not sufficient to prevent relapses, and therefore a long and fortified regimen may be recommended. However, probably what we would recommend is really to have a discussion with each patient to explain the pros and cons of each option. So fluoroquinolones are a key drug. We knew that before, and now it's confirmed even more, and that also confirms that the fluoroquinolone testing is essential for every patient with rifampicin-resistant TB. This is very important also because other recommended regimens by the WHO for pre-XTRTB show similar issues as the BDLC regimen, namely they have similar relapse rates and also risk of acquired drug resistance. We also think that specifically designed trials like endTB-Q with an internal control and sufficient time to detect relapses are optimal and needed to identify and improve further the treatment for pre-XTRTB. And finally, unfortunately, there are still major access challenges to the BDLC regimen due to the cost and access to drugs, diagnostics, etc. So while concluding, I want to thank again all the participants and all the teams that helped performing this long study, all our partners, the funding, the main funder, which was United, but also really want to thank MSF, who came in and really saved the trial and allowed us to perform it as planned, and Mark knows something about that. And with that, I thank you very much.